now to stress upon the benefits of cardiac MR in viability, I request Dr. Aparna to take it forward.
Thank you. So I'm going to campaign for cardiac MRI for the viability imaging. So we know we can assess viability using different methodologies. We saw how we did it on nuclear medicine imaging. We can also assess viability based on the membrane function and the energy metabolism, the contractility, the wall thickness, the perfusion, and absence of myocyte necrosis. All these can tell that the myocardium is viable. So MRI can use any of these modalities other than the actual metabolism to detect viability in the myocardium. So how do we do? So obviously contractility we can see by the usual routine cine SSFP. If it is hibernating myocardium, we can also do dobutamine stress in MRI. Strain analysis can also help. Wall thickness, we can beautifully assess using the SSFP. We have a very great differentiation between the myocardium and blood pool, and we can clearly with great precision measure the wall thickness. And perfusion we can measure at rest and stress. Dr. Richa will be talking about it. And the best thing on MRI is to assess the late gadolinium enhancement and to look for the myocyte necrosis and fibrotic tissue. So we all know the principle of how we do the LG for the infarct. We know that the normal myocardium, will take up the gadolinium, it washes out, whereas the infarcted or the scar tissue has a slow uptake, and at around 10 minutes we see the maximum difference between the two, and then we image at that time so that the scar will be seen as the enhancing tissue. And we have different sequences to bring out that enhancement, where we will null the normal myocardium and show the enhancement. So in MRI, we not only can assess whether there is infarct or not, we can precisely tell the location of which arterial territory it belongs to and how much of the thickness of the myocardium is involved. As we know, here there's no infarct, here there is a small subendocardial infarct which is less than 25%. So we know that there is that much thickness of viable myocardium remaining, which can be salvaged by revascularizing that tissue, whereas this can be a transmural infarct. So the exact thickness we can very clearly measure. So that is the main strength of MR, where the spatial resolution is very high, 1 to 2 millimeter, nothing else is coming to that level, SPECT or PET or obviously not echo. So that is the main strength. So in nuclear medicine, we can't really fully assess this, the partially viable myocardium, which can be better done on MR. Let me just show an example how it can help us to guide treatment. So this was a patient who had LAD and RCA already stented, and at present his LAD stent was occluded, and there was only this small focal stenosis in the OM. So this patient's MR now, we can see that in the LAD territory, So in the LAD territory, we can see there is gross thinning, so less than 5 millimeter, that itself is one of the indicator that it may be non-viable. And we can see that there is a transmural infarct. So we know that there is no real point of trying to open up this stent. Whereas in that OM territory, in the infralateral area, we can see that there is a hypokinetic small segment and there is no infarct in that area. So we can guide our treatment to open up this vessel now. What are the other advantages of MR? Obviously all the other things of availability, cost, and zero radiation. That is the main another advantage, so we can keep repeating it. Only some of the problems that we do face is the claustrophobia when there is non-compatible MRI, the implantable devices. We'll come into that also, what we can do in those situations. Coming to the sensitivity, specificity, etc. So MRI is quite similar to SPECT, and the specificity of dobutamine echo is better, whereas the sensitivity of PET, FDG PET is better. Just to show an example, like there can be a lot of false positives on SPECT because of other soft tissue attenuation. So there was supposed to be a fixed defect on stress and rest, and it was thought to be non-viable. Whereas on MR, we can see there is absolutely no infarct in that area. So there can be false positive on SPECT, which can be refuted on MR. What are the other advantages of MR? Other pathologies, which can be totally missed on other modalities, we can see better on MR. Like for example, this patient also had a hypertrophic cardiomyopathy as well as an infarct, which we will not see either on SPECT or PET. Other complications in patients with infarcts, like for example, thrombus. Again, it will not be picked on PET or SPECT. Complications like aneurysm, when we want to get a good spatial resolution and image this, obviously again MR is the best modality. For tissue characterization, to look for edema, microvascular obstruction, hemorrhage, area at risk, all these MR is the modality. So we can see here T2 stir showing the edema. The same patient has the infarct as well as an area of no reflow where there is a dark core, which is the microvascular obstruction. So obviously all these cannot be assessed in any other modality. So what are some of the issues with cardiac MR? We know there is claustrophobia. Some patients are not able to lie down. How do we do imaging in implantable devices? Sometimes there may be incompatible devices. And the artifacts, even if they are compatible, what about the artifacts? And what about renal failure? And the main thing of what Sir said, there's no metabolic assessment, only anatomic assessment. Let me say some ways that we can overcome. So we do have large bore magnets, and obviously we can counsel the patients, etc. What about implantable devices? There are more and more MRI conditional, that is compatible ones coming up, and wideband LGE can be used to overcome the artifacts with the like pacemakers. What about risk of NSF in CKD? So now more and more the latest ACR guidelines say we don't have to really worry too much about NSF, especially if we are using the macrocyclic gadolinium contrast agents. Obviously T1 mapping is the other thing, but it is not very specific. And what Dr. Vanessa showed us about virtual native enhancement with just the T1 mapping and the cine images, we are reconstructing the LGE images. What about lack of metabolic assessment? That was the other point. So MRS spectroscopy is being developed to try and get more metabolic information also in CMR. So in summary, I think CMR is one-stop shop where we can get everything starting from function. So obviously function MR is the gold standard, and to assess all the complications, to look at acute infarct, to look at area of risk, all these things, MR is the best modality. So before I stop again, like what everybody has been talking for last 2-3 days, just to say that whether we need to do the viability assessment or not. So at present, I think from whatever all the trials, this is the meta-analysis which is saying that it cannot either be affirmed or refuted at the moment. But this same trial which Sir had spoken about, even though the viable myocardium, they did not show that it was having any much correlation with recovery, the scar burden did have some correlation or like negative correlation with the outcomes. So if not looking at viability, maybe the scar burden will also help in future. Thank you.
Thank you, ma'am. That was an excellent presentation. Any questions from the audience?
Yeah, madam. No, not much debate, madam. No, I want to see that image which you showed actually.
I think I have a lot of support, sir, in the debate.
No, because you showed that image.
SPECT one, sir.
Yeah, SPECT one. Because that is showing uptake is not
Okay, sir, that is not my image, that is from this article.
So you told that is not viable or because it is showing
Not
uptake.
viable.
No, it is showing uptake.
Okay, sir,
So
this
there
is
is
from the
perfusion, there is uptake, so it is a viable. It
Okay,
is not false positive actually. It is the half of the myocardium is showing uptake. So that is one thing. Madam, and another thing, like in SPECT also, we see the wall motion, we can see the dyskinesia, we can say it is like dyskinetic aneurysm is there, but thrombus we will not be able to see.
Yes, sir.
So dyskinetic we can see in the wall motion.
And but even if you see the aneurysm, the exact details that are needed for surgery, that we
that
won't
is
be
not
able-
possible.
Yes.
So what I say, like viable thing we can see in PET, but scar will be more seen in MRI. That is the thing.
One question to you itself, Kamlesh, in that initially, a long time back, we always used to talk about balanced ischemia being a problem. Is that resolved now?
Myocardial flow reserve calculation quantification, it is resolved, but that is not available everywhere. So it is a big thing, like still it is there, but based on experience, like if you see more and more number of cases, then you can find out that also, balanced ischemia. So it is it is very difficult, but based on experience you can find out. But myocardial flow reserve, like as I told, new cardiac SPECT cameras, they are having a myocardial flow reserve assessment. With that we can see.
Thank you so much for the great discussion. I think we are surrounded by very nice people, so not much of debate. Dr. Aparna, you need to stay. So I would request again Dr. Gunasilan to felicitate Dr. Aparna.